I'm a nurse practitioner in Canada, and my role is to provide education to the community for various things, including trauma management, trauma stabilization. And I have one disclosure that this talk about deterioration actually came out from a nurse colleague of mine when I was an inpatient nurse practitioner. And there was a patient that was deteriorating on the floor that was a spinal cord unit, and it wasn't actually my patient. And the patient was clearly deteriorating, rapidly deteriorating. And so she asked me to step in, and I was assisting her to help her understand what was going on with the patient. And afterwards, when she stepped out, she's a very senior nurse, and she'd been in the division probably about 25 years, and she said, I was completely overwhelmed. I didn't even know where to begin, and she said, I felt really out of my element. And it's clear that this senior nurse wasn't out of her element. She really knew what she was doing, but she had some challenges sort of tunneling down all this crazy information that's going on while the patient's starting to look like they're moving into coma. And it made me as a clinician or as a nurse practitioner stand back and say, okay, so what is it about deteriorating patients as we witness it that kind of makes us question what it is we know, what intuitively know how to manage patients. And so what I've done is I've come up with a couple of protocols. One is called the STAMP protocol, which I'll talk to later on. But really stepping back and really deciding how do we, as clinicians, as nurses at the bedside or whoever it is, separate out how to manage all this chaos to help the patient move through and help you with your skill set. So this is called assessment of the neurological deterioration and what bus are you on. That makes no sense to you right now, but as we go through it, you'll recognize what we mean by trying to figure out what bus you are on. So these are two case presentations. I have hundreds of them, but I brought them just to really highlight. So you're working on a day shift and you're assigned to Bob. He's 59. So Bob's admitted for a resection of a meningioma. He's 2 days post-op, and you're giving out your AM meds, and his wife arrives, Carol. So Carol goes into the room, and at 10:15, she comes running out of the room and exclaims, "Help, my husband has chest pain." Or, "Help, I can't wake my husband up." So in scenario A, the chest pain, you whistle on your way, because you kind of know what to do. Even if you're not a cardiac nurse, you're oxygen, you're probably going to do blood work and ECG, you're going to assess the patient, whatever his vital signs. So irrespective of how long you haven't been in nursing school, you know how to manage a cardiac or a chest pain patient. But if you can't wake up the patient, suddenly she can't wake him up, suddenly you're not quite sure what's going on with Bob, and you're not actually whistling on the way because you're kind of upset, you're not really sure what's going on, and what do? We want to bolt for the elevator. So what we want to try and do through this is actually teach you actually want to bolt the other way. And the skill set that you're bringing to the bedside really has to be acknowledged of what you have and what you can bring and what you understand. And I think sometimes during these crazy periods where patients are crashing rapidly, it's that somehow or another it seems like someone sucks our brain out of our head and takes it to another room, and we're standing watching these patients as they get sicker and sicker. So really today my role, or what I hope to do, is really review what deterioration is, explore what consciousness is and or arousal states, and how patients begin to deteriorate and what that suggests is happening. Look at some case presentations that there's hundreds of them. You all have hundreds of them as well. Hopefully assist in the development of critical thinking in critical situations. So how do you separate out all the junk? How do you separate out the noise? And help you recognize you actually know this, and I'm not going to give you any information that you don't know. And it's really, I'm just twisting it a wee bit so that when you actually, about halfway through, your light bulbs will go on. That's the fun of this talk, because people go, oh, okay, now I actually get it. Because what happens is that I'm not providing you with something that you're going to have to write down and say, oh, you know what, I've never learned that before. So you all have this information, but I'm just moving it in a different angle. So what is deterioration, and what does it mean? So it's really what's defined as the state of a worsening of any kind of medical condition. And we know that for some patients it's expected, our very traumatic brain injured patients that are DNRs or subarachs that are DNRs, but it can be unexpected. And it accounts across the world for about 10 to 15% of all hospital deaths in westernized medicine. These are unaccounted. These are really deaths that we weren't expecting. And it can happen at any point along the continuum of care. Though we do know that some patients, for example, the eMERGE patient, the ICU extended stay patient, often has a higher risk of suddenly deteriorating than the patient that's admitted for something that's quite routine. But we do know statistically that the majority of patients actually don't deteriorate suddenly. And I was involved in my hospital. I had a code pager, and every time a patient deteriorated in our hospital, I was paged. And so my role on that was really to step back and say, in retrospect, what was going on, and is there something we can learn from this experience? And what we realized, and this is supported, is that people actually putter along. And within around 24 hours of their acute deterioration, they're actually showing subtle signs and symptoms that they are moving towards crashing out on you. But what's more of interest is about 40% of all patients that we find at the bedside that are deteriorating require CPR or advanced life support. So we're catching them late. And so there are some things that we think about is how are we catching them late? Why are we catching them late? And irrespective of cause, though, whether or not it's a patient whose blood sugar is 2, or whether or not your patient has a brand new re-hemorrhage from a subarachnoid hemorrhage, all deterioration moves into neurological deterioration. And I'll talk a little bit about why that happens. So there are some obvious challenges with deterioration. First is that there can be no observation for long periods of time. So when you're a night shift and you have 4-to-1 or 6-to-1 patients, which we have 6-to-1 at nighttime, there often is no change in vital signs detected. So you get at midnight, you do your vital signs, and then oftentimes you do walk-arounds, and sometimes you don't get to the vital signs until 4 or 5 in the morning, and something's happened to the patient between that because you may have had a sick patient in another room. Okay? Or the patient's had an unwitnessed seizure and something's going on and suddenly you can't see what's going on. There's no recognition of the importance of the signs. There's uncertainty of the influences on the presentation. We've added a new medication that actually interacts with another medication that can cause deterioration. There's no optimal charting format. So for example, when you look, and that challenges our inter-rater reliability. So when you're looking at a patient and you're saying, well, I think the patient has severe weakness, but you think the patient has mild weakness or moderate weakness. So when I come into the round and I see that you think the patient had moderate and I have severe, is that actually new? Or is it that we've all looked at the information differently? There can be lack of critical knowledge about what the signs reflect. And that's where we are caught most often. Or the skill set may be incongruent with the patient population. We had a nurse who was transplanted from lung transplant to neurosurgery, and the patient was quickly or slowly moving into respiratory failure. And to her, working in lung transplant, respiratory, that's no problem. And she actually witnessed the patient getting sicker and sicker, but her patients on the lung transplant were way sicker than this patient. And so she actually, the skill set was actually quite incongruent, even though she was quite a lung expert, was incongruent with the neurosurgical population. Or no action was taken. So there's a delay in reporting. You don't want to wake the staff up in the middle of the night, okay? Or there's a delay in treatment once it's detected and reported. So you call the resident on call and the resident says, yeah, I'm intubating someone in eMERGE and I'll be up there in a couple of hours, or whatever the system is. And the systems vary across each organization. But what does show up in the literature is this is not profession neutral. I mean, it is profession neutral. So every profession runs into these challenges, whether it's nursing, physicians, PAs, NPs, all these sorts of groups that manage people, they all can run into these difficulties in reporting and management of deterioration. So I always call these the cases of uncertainty. So we have an 82-year-old lady who's admitted to neurosciences who's awaiting transfer to medicine. She was in eMERGE and they didn't want her lying down there longer than needed. And she was admitted for a UTI because she was found delirious and febrile by her family. And she lives alone. Past medical history is for coronary artery disease, COPD, type 2. Typical 82-year-old comes in with comorbid illness. Her remitting medications are unchanged, but they add IV Cipro to help with the UTI. Her family asked for a sedative to help her sleep because they believe it's worsening her delirium, and nothing's worse than an 82-year-old delirious patient who's not sleeping, right? So she's given a sedative, and on night rounds she's found to be sleeping soundly around 2 a.m. And then the nurse goes in at 6:30 in the morning, she's obtunded, and they had to intubate her at 6:30 in the morning. Okay? So then you have to think of, well, what's the idea? What's the cause? Any idea of the cause? So what's that? Yeah, absolutely. Right? So clearly a metabolic issue led to a neurological change that caused the patient to require intubation. So when we look at causes of deterioration, we can almost separate them into one or two causes. Okay? Challenges with the assessment of this patient. So let's say you're the nurse that's gone in at 6:30 in the morning, and this patient needs to be intubated. The challenges is that you're not sure about the expediency of the symptom onset. Did they happen 5 seconds ago, or did they happen 2 hours ago? There may be lack of obvious symptoms. You may actually not see anything that you can determine what's going on with the patient. The patient clearly can't tell you anything, and the only person that spared the anxiety through all of this is actually the patient. You're unable to compute the presentation with a possible diagnosis. And what I mean by that is everything you could possibly think of in your whole history of your career is spinning around in your head of what could possibly cause this lady to require intubation at this point in time. Okay? But the difficulty is the assumed expediency required to complete the exam, though expediency is often required. So what I mean by that is, though you've got to decide where you're moving, it actually complicates things, but you have to decide where you're moving. Okay? So that begins to limit the confidence of the person at the bedside. Whether you're an expert or whether or not you're not an expert, you've still got to figure out how to move quickly forward with the information that you have at hand. Okay? So now we're going to talk about the nuts and bolts of deterioration. So we do know as deterioration or changes in awareness or consciousness happen with patients, we initially have changes in awareness. So those patients should go in and say, "Hi, Mary, how you doing?" And Mary has no idea where she is. And she's moving into like a delirious state. But at this point, Mary needs minimal stimulation. But then as patients begin to move towards that box of coma, you do have changes in arousal. So Mary, who was awake and alert before, and maybe a bit delirious, now requires more moderate stimulus to wake up. So now you got over, instead of talking to Mary, you've got to shake Mary, rub her arm, yell at her, trying to wake her up. And then as patients even move further into coma, you require significant stimulus and central pain. Now in Canada, we've banned the sternal rub. You cannot do the sternal rub in Canada. It's against the law. It's against the Canadian health policy to do the sternal rub. Because if you've ever seen a tea and toaster, a little old lady who's got the washboard chest, and they're doing the sternal rub every 15 minutes, if that was my mother, we would be having conversations. So we have removed it from our neurological assessment across all neurosurgical centers. So we do not do sternal rubs anymore. We do the trapezius, and we do the finger in the eyeball. I know the finger in the eyeball sounds kind of crude, but it's not the finger in the eyeball. We get the thumb and we push it on the orbit. And all our nurses do the trapezius squeeze. It's like the Spock thing, but we have totally eliminated sternal rub as a source of central pain. But anyway, that's a different conversation. So we do know, though, as patients move towards deterioration, we have changes in awareness, changes in arousal, and then patients move into coma. And as they stepwise progress, we recognize, of course, as you know, the patients need more and more stimulus. But the question is, why do they need more and more stimulus? And that's what we're going to talk about. So deterioration really results from two things. If we categorize them into two things, we categorize them into changes in CNS structure. So these are things that occur within that closed bread box, or they're related to changes in CNS support. And when we talk about those, now I'm going to break them down into what changes these represent. So changes in CNS structure, and this is a beautiful MR, is it not? There are two things. We do know that consciousness involves two things, awareness and arousal. And the awareness is really the cortex. Anything above this little arrow here, which is your thalamus. And your thalamus, as explained yesterday, is around the size of 2 quail eggs and sits right beside or kisses the third ventricle. And the thalamus is really the airport of the central nervous system. Everything kind of moves in and moves out of the thalamus. But what happens is we have our awareness system, and these are all the association tracts, and the arousal system, which includes the thalamus. And just so happens that the thalamus also contains the pain center and the brainstem, which is your reticular activating system. So consciousness involves both awareness and arousal. So awareness provides us with our high GCS scores. Okay? It includes all high cortical function, including motor, sensory, association areas, speech, hearing, and our pain response. And here is your thalamus right here, these two circles, which you'll see a lot of today. We'll be talking a lot about these today. But information comes up from the periphery, enters the thalamus. The thalamus at that point, it decides what it wants to do. It sprinkles it around. It sprinkles it across the central nervous, up into the cortical areas, into the parietal lobe or the frontal lobe. And then eventually those decide what to do with the information, then it shoots it back into the thalamus. And the thalamus again decides, does it need to go south or does it need to go somewhere else? And there's certain things about the thalamus that we also recognize. For example, the thalamus and the top of the midbrain loves Gravol. So that's why you ever take Gravol or you give patients, we use Gravol. Sorry, so that would be like an antiemetic that puts you to sleep. What do you guys use here for antiemetics intravenously? Zofran. No, Zofran doesn't make you sleepy. Okay, like a Benadryl or a one of those. Okay, I hear all sorts of things. For us, it's Gravol, but there are certain sections in the thalamus and the midbrain which love these products. That's why patients go to sleep when we give it, because it affects the reticular activating system. Okay. We also think this area is responsible for delirium, which it scatters information around. But we do know that awareness can attend mostly to the environment, and when patients come in and they get increasingly more delirious from their low blood sugars, it's awareness that is affected. It's the cortical function that's affected first, not they don't move into coma right away. But we do know that it's extremely sensitive to metabolic derangement. So as blood sugars begin to drop, patients they have changes in awareness. When patients get delirium, they have changes in awareness. So it's extremely sensitive to metabolic derangement, but it also has to require bihemispheric. And what I mean by that is if you have a patient whose blood sugar is dropping, they don't become plegic on one side or hemiplegic. It doesn't say, well, jeepers, I think I'll starve the frontal lobe of sugar today because that's where I want to go. It has to include both sides of the brain, and that's why patients whose blood sugars are dropping never are hemiplegic, because suddenly the brain says, oh, okay, I think I'll go there today. It has to include both systems, both sides of the cortex or the awareness centers. Then we have low GCS scores, and this is your arousal system. And if you have a goldfish, if you have a dog, everything has an arousal system. This is our primitive system that keeps us alive and intuitive and instinctive. And this is where everything kind of begins or ends. It includes our primitive responses, which we talked about yesterday during vital signs. So this is the gag reflex, which is right down here in the medulla, whatever you want to call it. There's the corneal reflex, and way up here are the pupils. And what happens is information comes in from the periphery. It turns the light switch on of the ascending RAS. It goes into the thalamus, and the thalamus decides where it wants to go. It's very deep in the central nervous system, but it also provides specific pathology. So for example, right here, in this part of the RAS, under this little lobe, is your third nerve. Okay? So when your third nerve becomes squished, it's actually in this area right here. So that's why often patients whose pupils aren't working, oftentimes already are moving into coma quite quickly. So we do know it's a danger zone. And we know when GCS is 8, we intubate. That's the kind of language we use. But awareness and arousal are deeply and interconnected through the thalamus and the reticular activating system. Okay? Now we're looking at CNS support and maintenance. Okay? And we're talking about, let's talk about the products that are going to the central nervous system, not actually what's in some way supports it. So we do know that entry of blood and products, oxygen, glucose, and waste, are tightly managed by your autoregulation and your blood-brain barrier, which is really a finite extension of your circle of Willis. Okay? CNS function and survival is highly dependent upon glucose and oxygen, and the CNS almost has no reserve. So once you run out of glucose and oxygen, you move to a glycolysis state, and then you move to an anaerobic state. And that's when all this toxic stuff starts to happen within the central nervous, and it begins to misfire. And we do know that it's very intolerant, the central nervous system is very intolerant to lack of oxygen and lack of glucose. Awareness is affected with a decrease of 20% supply of quality, and obviously the gray matter is affected first because it's the most selfish of the central nervous system. The gray matter receives about 55 mils of blood in about 100 cc's of brain tissue, so it's very selfish. But you have to recognize that if you're in renal failure and you're sending your creatinine to 700, and that's creatinine is also swishing around in your central nervous system trying to supply the brain with stuff, there's no quality going there. So there has to be something about the contents that are going to the central nervous system that also affect how the central nervous system will work and how that affects its efficiency. So knowing that, so we know that there's some things that affect consciousness. So if we look at a supportive problem, which we consider, if we think about a camp or think about which way our bus to go on, this would be the metabolic system, the support system. So changes in it really reflects the changes in the amount or the quality of the blood or the blood products that are going to the central nervous system and up to the brain. So it can be a lack of total available oxygen. So the patient that's hypoxic or the patient's anoxic, patients with chronic anemia, or the acute asthma patient, or the patient in respiratory compromise or depression. So thing that is not providing oxygen, or as we heard, giving patients old blood, which is actually something I took away from this. There could be lack of total volume. So the train is empty, so there's nothing on the train. So patients are hypovolemic, or the patients are hypotensive, or the patients are in any type of shock, including distributive shock. Or there's lack of quality going to the system. So what we're sending up there is actually not worthy. The CNS can't do anything with it. Can't do anything with a creatinine of 700. So it could be acid-base problems that are happening with the patient. Patient's got chronic or prolonged COPD, or the patient's hypoglycemic. So what we're sending there is of no value. So it's either not available, there's not enough of it, or it's of no value to the system. And the system has to figure out, so what are we going to do now? And when the system decides, hey, I can't manage this anymore, then we start to see changes in awareness and eventually changes in arousal. Or we have a neurological problem where the blood-brain barrier is no longer able to do its job. And it's either no longer able to do its job because there's membrane instability, so there could be inflammation, or it's not working very well for whatever reason, such as bacterial meningitis. There's a trauma to the head, or there's a space-occupying lesion of any sort, blood, all these sorts of things. But it also could be the fact that the endothelium and the neurons can't work because there's stuff not going to it, which is secondary to metabolic. So that leaves you with two really main choices of overall cause. Okay, so we have a metabolic issue, which are issues really that occur below or begin below the neck. And then we have a neurological problem when issues begin above the neck. Okay, and recognizing that both eventually lead to neurological changes. Okay. Here, for example, this is very classic. So this, even if you're not rock star radiologist, you would say, that doesn't look very good. I'm not quite sure what that is. Okay, so this patient has bilateral thalamic tumor, and this patient was actually quite a sad case. We call this in Canada the toothless smile. So we have a cistern here, the quadruminal, it's a cistern here. There's a third ventricle, but these are the eyes that are closed. And we call this the toothless smile because there's a happy face. And this was a young woman who was a type 1 diabetic that hadn't been heard of for a few days. And when they went to find her, when they got her to the EMS, got her to the hospital, had given her an amp of sugar, and by the time they got her to her hospital, her blood sugar never got above 0. And of interest, and you may not be able to see it back there, where'd my mouse go? This and this are slightly different colors, right? So this is what we call loss of gray. This is what we call, this is called hypodensity within a CAT scan. And this is all infarct. So she's completely infarcted everything but except the base of her cerebellum and a bit of her occipital lobe. So she succumbed to her hypoglycemia. So irrespective of, she at home would have showed changes in awareness first, then changes in arousal. And as the metabolic system continued to not provide quality products to the central nervous system, it just shut down. And so she would have showed up in coma and this patient both shut in coma, and the young lady on your left-hand side succumbed to her sugar problem. So we need to consider consciousness this way, and I always try and describe it like a bit of an office building. So the ground floor, the first floor of the office building is your reticular activating system. And that's what we think about the energy, okay? So for example, when you want to wake up, your intuitive system turns on your ascending reticular activating system, and you wake up and life's good. And the top floor of the office building is the cortex, and all the office lights are on. Okay, let's think about it that way. Okay, so changes in awareness, okay, energy is moving from the ground floor, but is not getting to the top of the building, or the top floor, and it could be scattered, okay? Or there's broken circuits, which we can see in patients with association problems or tumors, something sitting in the white matter tracts. And then we can think about this sort of as a delirious patient where energy is actually scattered. So we do know that the midbrain and the thalamus and the forebrain actually have 4 or 5 tracts that connect our ability to engage in our environment. And we do believe, well, the research suggests that one of the tracts is actually the one that moves patients into a delirium. It becomes hyperactive, and it can't sort out the information that it's receiving as if it's appropriate or not appropriate. And what happens is these tracts spin on each other, and the delirious patient gets more and more excited. Their central nervous system goes like this and just spins upwards. And eventually that spinning burns itself out, and the patient moves out of their delirium. So we do know delirium is a metabolic problem. So they spin up, the system gets a little out of control, it sorts itself out, it burns out, and then the patients move out of their delirium. So this is the case of the sleepy nurse. So you were signed up for an outstanding conference, okay? Offered at UC Davis. It's 8:30, well, it's not 8:30. And you're sitting in the lecture hall, you've sent your kids to school, you've had a cup of coffee, and now you're sitting comfortably in the chair. The light's dim, you notice you can't stay awake, okay? And you begin to bob. Your head does the head bob. We've all done the head bob, right? And that's and no matter what you do, you cannot stay awake, right? So what's actually happening to you? You're not moving into coma, so what's happening to you? What's happening is that your office building, okay? Your office building is saying, hey, you know what? I think it's time for you to go to sleep, and your sleep is here. And so what it does is it begins to involuntarily shut down your cortex a wee bit. But before you fall asleep, and you say, man, boy, that felt good. But what do you try and do? You try and turn your office lights back on. And so how do you do that? You re-engage your cortex. And unconsciously, you shift in the chair, you put your glasses on, you put your phone away, you move around, you have a drink of your coffee. Because what you're actually trying to do is you're trying to re-engage your thalamus, your reticular activating system, which is right here, to actually turn your light switches back on. And by attending to various tasks, so if I just did this, I'd be turning on only one side of my brain, my frontal cortex and my parietal lobe, so I know whether I'm holding a bottle. But if you move around in your chair and you try and attend to listening, you actually turn more of your cortex on. So your chances of staying awake are actually greater. So the more you turn your light switches back on, the more your chances you're going to stay awake. Or you get up and walk out of the room. Okay, so that kind of makes sense, because what you're doing is you're trying to re-engage your cortex. And as we're doing that, that's no different than when you try and wake up a patient. You're trying to also re-engage their thalamus and their cortex to see where is the problem getting stuck for this person. Okay, so Chester, this is quite easy for all of you, is 31. He's a type 1 diabetic, admitted after being found unconscious on the street. His initial CT shows a small traumatic contusion, which we admit. We admit contusions because the contusions can grow. So 8 a.m., Chester was given all his AM meds, and he's transported to imaging for a CT head. Chester returns to the floor. At 10:30, Chester is found diphoretic and incontinent of urine. Okay? His vital signs are heart rate's 120, respiration's 8, BP's 130/80, and his temps 37.5. Okay, so What's going on? Anybody have any clue? Hypoglycemia. Okay, couple of things though. What's interesting, so you got the type 1 diabetic and the diaphoresis. That's kind of what I call a bit of a no-brainer. But what else is flagging you as a nurse? Incontinence, okay, which is kind of a weird it's kind of a weird thing that doesn't kind of fit with the diaphoretic patient. But what else? Yeah, it's okay. Not so. Yeah, it's got a respiration rate of 8, right? So what do you think's actually happened to Chester? What happens when you, we just had a talk just before me, we had a great talk on a problem. He's had a seizure, okay? Because what's happened is his blood sugar's dropped, right? Because we gave him, he's a type 1 diabetic, he had insulin and went to CT, came back, he left at 8 o'clock, so in Canada breakfast is 8:30. So he missed his breakfast, came back and his blood sugar crashed. So what happened is he had a seizure, an unwitnessed seizure, and he became incontinence, which is very common in our seizure population. But everybody gets a diaphoresis and the type 1 diabetes. And I said, yeah, but why is he incontinent? And he goes, yeah, I'm not sure. But the clue is, and when you look at his vital signs, I would say, well, that's kind of not usual for someone who's 31, heart rate of 120. So something's happened to Chester that perhaps no one has seen, okay? So when we look at this, so could this be why most metabolic patients have changes in awareness early? Because don't forget the elevator, the office building is not going on fully, and they become more obtunded if the metabolic problem is not corrected. So the longer we leave Chester, it's my chain again? Oh, I'm sorry. Okay. The longer we leave Chester, the more neurologically he becomes impaired. Because less and less energy is going to Chester's floors. And as the office building from the top floor begins to shut down, it moves closer to the ground floor. And the ground floor is the coma center, which is the thalamus. Okay? And again, it needs to include both hemispheres. Therefore, changes in neurology must be a late sign in a metabolic problem. That makes sense, right? Good? Okay. So now we have Ramin. He's a 55-year-old. Onset of right-sided weakness, which he noticed when he woke up. He has a history of hypertension, smoking, he's slightly overweight. He's admitted with a diagnosis of a stroke. And he's initially awake and alert, but you notice that he's getting more drowsy as the morning progresses. And his weakness worsens, now he can't move his arm or leg at all. And his right pupil becomes unresponsive. Vital signs, actually, his blood pressure is pretty good. Heart rate 76, respiration's 20, and his temp is unchanged. So his vital signs are stable, they're not changing. Okay, but Ramin moves into coma, and he's brought to the OR for a decompressive craniectomy. Why did he lose consciousness? ICH, yeah, he could have converted, I don't know if he's had TPA. Okay, but if we look here, so this is a DWI, diffusion weighted image, and the reason these go white is because water molecules, when they can freely diffuse, don't change color, but when they're stuck, they go white on a DWI, diffusion weighted image. So here is Ramin's initial stroke, lovely round circle, that's how much room it took, but as his stroke evolved, it took up more room, and more room. And as it took up more room, what's this little star? There's his thalamus, his coma center, and Ramin moved towards coma. And just as he did that, and as we see this bigger circle, as it went down, and this is where your third nerve is, it's right under there, he pinched off his third nerve and he blew his pupil. So his changes in consciousness is actually, though it begins at a different spot, okay, both our Chester and our stroke patient ended up squishing off the main floor of the office building or the thalamus, which is where where your really coma centers, and the top of the midbrain, which is right here. Okay? So that's why I said, what bus are you on? We think about the two buses that you're on. You're either on the neurological bus or the metabolic bus. So when you're going to see a patient and they're looking kind of lousy and you're not sure which way it is, because if you think about all the metabolic things that could put a patient into a metabolic disease state that causes deterioration quickly, or it's going to be a neurology problem. Okay? So both patients moved into coma because both ground floors were compromised. So when you think about it, what bus do you think your patient is on? And the question is, how do you determine which one? Okay? And again, I'm going to not give you any information you already don't know, because things you have to ask yourself are, what are the vital signs doing? And what are the pupils doing? And I'll show you why that is. Okay? So this you'll see a lot of, because I like this picture because it's a really good picture. This little X is known as your vital sign center. We all have one. It's in the base of the brainstem. It's in the medulla or medulla, whatever you want to call it. And what is the purpose of this? What's the purpose of the vital sign center? In it is blood pressure, heart rate, all these sorts of things that it manages. What's its purpose? Keep us alive, right? But one thing we do know about the vital sign center, it responds instantly to metabolic derangement. Okay? So when anything changes, it's really quite as you know, it's an unconscious center. You can override it consciously, but it's an unconscious center that keeps my blood pressure going to my brain, even though I've been standing here almost most of the day, right? Because if my blood pressure can go to my head, I'm going to pass out. And my heart rate has to maintain that, my oxygen, all sorts of things. So as your oxygen changes, your vital sign center it's like the bus driver. Okay? It affects the lungs, it affects the kidneys, does all sorts of things, but it responds instantly or instantaneously and unconsciously to metabolic derangement. Okay? And we know, as neurology nurses, that when a patient starts to have vital sign changes, okay, we know they are in serious trouble. And really, when patients move into serious vital sign changes like Cushing's triad, they only have minutes before they actually are probably going to succumb to their injury without intervention. So we do know that if it's a neurology patient, the vital sign center is really far away if the patient has a problem above the midbrain. So our stroke patient was way up here, and it was only till he moved down to here that he moved into coma. But he may or may not, most likely didn't have changes in his vital signs. Whereas our patient here, okay, in our patient who's hypoglycemic, as their sugar begins to drop, the body says, your sugar's dropping, I better start to push more glucose into the central nervous system so your heart rate goes up. Right? So sometimes if we're standing at the bedside and we're starting to figure out what is wrong with our patient who actually can't tell us what's wrong, the first thing I say to all the staff when they're calling me on my phone and saying, you better get your bum up here because something really bad's happening, I say, tell me what the vital signs are doing and are they different? Because almost by that I can almost categorize which bus I'm going to be on by the time I get there. And I can also ask for stuff while I'm on my way. Okay? So if the problem is metabolic, vital signs will often change very early. Okay, so low sugar, low oxygen, you have an increased heart rate, increased respiration rate. A low BP will give you increased blood pressure, increased heart rate, eventually increased respiration rate. In neurology, pupillary changes or coma will often be a late sign, right? Because we haven't reversed what's going on metabolically. And the patient will eventually lose compensation. So until we reverse that metabolic problem, okay, things will just continue to truck along. So the office building will begin to shut down more and more and more the longer the metabolic problem is not resolved. If the problem is neurologic, vital sign center is often very far away. Okay? And vital signs changes will be late. Because you'll see other problems before you get there. Because if the vital sign center is way down here, there's lots of stuff in between here and there before you'll get changes in the patient's vital sign, overt changes in vital signs. Okay? The pupils, which are right here, if the problem's up here and is going this way, you're going to get changes in your pupils before you get changes in your vital signs most often. Okay? Critically thinking, what else do we need to think about? Well, we know the pain center is here. Patients will eventually lose their ability to respond to pain the closer you get to your pain center. And that's when it becomes, and beyond that, it becomes, you have these weird responses that we see, the decortic and the decerebrate. So what also is here, from the pain center to the vital sign center? Well, the pupils will dilate once you get to here, and once we move into the pons, they become pinpoint. The respiratory pattern, okay, respiratory pattern is in the pons and medulla, so pattern changes, not the rate, but the pattern will change. And we've all seen pattern changes in patients. And the patients will lose their corneal reflex. And then eventually they may lose a gag reflex. So there's a lot of stuff in here before we have obvious or overt vital sign changes. Now this isn't, well, I was told it was this or it was that. But this is really when you're standing at the bedside, what are we doing with this person? Which bus are you really going to be on? And this is why Cushing's triad, the stuff that we see, is a late sign in neurology, because by the time you get to Cushing's triad, the patient's gone through all sorts of things that you've already witnessed. And that's why we see it as a progressive problem. So we have Joanne. Joanne's a 38-year-old frontal lobe tumor, and she's 1 day post-op. She's mildly overweight, got a BMI of 32, but she's otherwise healthy. She's on Topamax, which is an anti-seizure medication, birth control pill, and Pantaloc, which is a PPI. At 10 a.m., she gets up to the bathroom, and she walks to the nursing station and asks for analgesic. Okay, 10:30, the nurse returns to the floor to find Joanne, returns to the room, find her unconscious on the bed. Okay, these are her vital signs. Okay, blood pressure, it's probably a bit low. Heart rate's a bit fast. Respir a bit fast. SAT's not so great given that she's 38. And then she calls for help, and 5 minutes later, these are her vital signs. Okay, so what bus are you on? Even though you kind of know you're on a bad bus, okay? What bus? Metabolic, right? And any provisional diagnosis? Yes, I heard it, PE, sheet of PE. So this is a classic. So even though she's unconscious, you already know you were on the metabolic bus, okay? So what we're gonna do, we're gonna move you from the scary face to the happy face. Okay, so what do? You don't panic. And that's easy for me to say. But when you're at the bedside and the patient is moving quickly into coma, and the family is there, and there's all sorts of people around, it's very easy to get panic and to get quite overwhelmed. But do your best not to, and have some faith in the skill that you're bringing to the bedside, because you all have it. Okay? And think about, are there any overt changes that I'm seeing? Are there overt changes in neurology? Okay? Are there any overt changes in vital signs? Because it kind of gives you an idea if you need to order, if eventually the patient's going to move to CT, or you're going to order a CT, or whether or not the patient actually needs some metabolic workup, metabolic stability. Establishing a differential diagnosis during deterioration. So what do you need before you decide what to do? You have to take a deep breath. And does the patient need an airway? Now in our organization, if the nurses don't know, we ask them to stick in an airway. And if the patient tolerates it, we know the patients are in serious trouble. And if they spit it out, we recognize it gives us a bit of time. Are the vital signs stable? And what are you seeing and what are you not seeing? So if a patient is moving everything, but they're kind of moving in, sort of slowly moving into unconsciousness, I'm thinking most likely what I'm looking at is a metabolic problem and not an isolated neurology. Okay? And consider the differentials. Consider what's going on, and consider the really bad things to the bad things. Okay? And know when you're over your head. We all are there. We've all been there. I could tell you stories that'll make you laugh, but so what we have our patient presentation, what the patient's doing at the bedside in the bed. You have to think about the presenting illness. Okay? If the patient presented with a tumor, chances are the patient's either going to have a seizure, or the patient has edema that's worsening. If the patient's admitted with hemorrhage, I'm not thinking that suddenly the patient's grown a tumor and that's taking up space. Have to think about the age of the patient and the comorbid illnesses that the patient has. Have we added anything new? So the things you really need to ask yourself, is there anything different that's happened to the patient within the last couple of hours or the last day? Did they add a new medication? Okay, that interacted with the medications that we weren't aware of. So what do? We always do the GCS. Well, we do the GCS on a normal neurology floor. Some people, we do the NIH stroke scale. In Canada, we do the Canadian Neurological score. But we've all been trained to do the CNS. But what's the CNS actually testing? Right? What is it actually looking at and how is it developed? So it's really testing how close you are to the ground floor. The CNS was started many years ago and was really looking at the assessment of patients with brain trauma. And though it's a worldwide scale, there's some intuitive limitations to it, including that it's not as precise as we'd like it to be. But we all know it and everybody can give us the information. So it really asks you, how close are you to the base floor of your office building? So what do we need to do? We need to wake up our patient. Okay, the more stimulus that's required, the closer you are to the ground floor. That means that the energy is not getting there for some particular reason. The more stimulus that's required, obviously the bigger the problem. How much is needed? Way up here, okay? All we need to do, and verbally, is equally as stimulating to the reticular activating system as is physical movement. So touching a patient is actually equally stimulating as yelling at the patient. It both wakes up the RAS. But if you're waking up the RAS, you rub the patient and yell at them, that actually can turn the office building on a little bit more. And the closer you get to this little fellow, this is the midbrain, or the closer you get to this, obviously the more and more and more stimulus is required. And that's what the GCS is testing. So when you look at the eye response, opening eyes, opens to verbal, opens to pain, and no response, I'm asking myself, how close am I to the ground floor? How close am I to the center where the patient may eventually lose their airway? So we know when patients respond to verbal or respond to eyes open, that it's above the ground floor. As the patient moves their eye, opens their eyes only to pain, I'm at the ground floor, just slightly above it. And when there's no response for some particular reason, the ground floor is not being turned on. Okay. If we look at verbal again, we know that verbal is just as exciting to the the RAS as is physical. So talking and confusion, we know that the information is probably just getting scattered up there for the confused patient, but it is still leaving the ground floor because the patient's looking at you. Inappropriate words are barely above the ground floor because when it leaves that floor, it's getting scattered perhaps into the wrong space, or the space isn't working as well as it should. Incomprehensible sounds, we know that it's at the ground floor because what is getting there, it's just getting there, but the ground floor is not sure where the energy should be going. It's kind of scattering it around just a wee bit to the first or second floor. And patients with no response for whatever reason are below the ground floor. And so we're looking at how close are we to the thalamus and the midbrain. The motor response, the 5s and 6s are above the ground floor. The patient that withdraws is really at the ground floor. The abnormal flexion and extensions really speak to where you're stuck below that. So for example, flexion and extension are really, in flexion for example, that's between just south of the thalamus into the midbrain and upper cerebellum, where the different tracts coming down from the cortex have to compete with each other. And when they compete, the one that loses is the one that does this. So patients have a mummy baby look. They pull their arms in and they extend their legs. So these competing tracts are doing this, and one is overriding the other. And when we get down to extension, that's no longer the issue, and patients are extending. So we do know that. That's why when we're looking at patients in coma, when there are flexions or extensions, we know patients that are extending are worse than patients that are flexing, simply because of where the tracts are as they come in and out of the brainstem. And we know that patients are doing nothing. They're really below the ground floor, and the problem is either spinal cord or brainstem. So the GCS really is testing, again, you're hearing this language, ground floor, because really the GCS is really trying to look at how close are we to the brainstem and what is the health of the brainstem. Airway, we assess airway and breathing, assess the pattern, assess the sound, and look for chest expansion, which is normal. But the pattern of the breathing really comes from the pons and medulla. So the chain-stoking patient, sometimes it's pontine medullary treble. So the rate, okay, that is medullary respiratory center, but the damage of the pattern comes from the pons and medulla. So the pattern is a worry for us. Okay, and if you're concerned, which we do, we ask our nurses to stick in an airway. Okay, and if the patient sticks in the airway, if you stick something in somebody's mouth, even if they're moving towards coma, okay, you intuitively or instinctively will spit it out. But if the patient doesn't spit it out, it gives us a worry that the patient's not protecting their airway or moving towards not protecting their airway. And that means either the gag's not working well or there's a misconnection between the RAS and what needs to happen. So that's why we leave them in. In motor, what are we seeing? Is the patient moving everything? Sometimes what I do is when they're moving into coma, I lift both their arms up and see if they fall at equal rates. Sometimes, because patients often can't tell us anything. If they're working well, everything looks like it's working well, okay, then the problem is not up here. If the patient is not moving things, it's here. I mean, if the patient has difficulty or things are getting stuck, it's stuck here. And if there's no response, we're still looking at the brainstem because the pain to cause motor is actually not getting to the pain center. Okay. So one thing we know about pupils is pupils are the single indicator. Though motor is a better scale for long-term outcome, it's a best predictor. Pupils are extremely resistant to metabolic derangement. So when you're going to see a patient whose blood sugar is 2, their pupils are still reactive, right? So the pupils are extremely resistant to metabolic derangement, and only late into this unrolling or constantly rolling metabolic derangement that gets worse for the patient do pupils become involved. And so our young lady who had the huge hemispheric infarcts had blown both her pupils by the time she arrived at our organization. And they knew the pupils were blown when we were giving her sugar, but she was young and we didn't know what was going on in her head. But clearly the pupils were blown simply because the lack of ability of the CNS to work had reached the area that it shut down the base of the brain or the midbrain. Okay. So when we look at bringing this all together, okay, so if we have changes in awareness, it can be an early sign in neurology, but it's less common than it is in metabolic. If we require a lot of stimulation, it's actually quite early in neurology, but often later in metabolic, because don't forget, awareness is affected most often firstly in metabolic disease. Unilateral sensory change is actually really early in neurology, but very rare in metabolic disease. Okay. Breathing rate changes are late in neurology and early in metabolic, so we're talking about the rate, not necessarily the patterns. The patterns of breathing are very late in neurology and late in metabolic, because the pons and medulla really are the pattern of the respiration, not the rate of the respiration. So we know pupillary changes are very early, okay, in a neurological patient, and very late or coma in a metabolic patient. And vital signs changes are very early in a metabolic patient, because don't forget that little tiny nubbin, which is about the size of half your fingernail, is actually what drives our metabolic system and keeps it intuitively in check. But it's a very late finding in neurology. So the patient has to go through all sorts of things before they'll move towards Cushing triad. So in conclusion, when you go to see a patient, think about what bus you're on. Consider what the pupils are doing, and are there any changes in vital signs? And that's really what you need to think about. What are the vital signs doing, and what does that mean to my patient at the bedside? Okay, I think that's it. Yep, that's it.